Consent lady. Okay, everyone, welcome to Forward, the podcast, the Forward Thinking Chiropractic Alliance. I'm your host, Dr. Bobby Maybe, and our guest today is Dr. Bill Tortoriello, or William, or Dr. Bill, the Dr. Bill and Dr. Bob podcast. That's great.
Yeah, there you go.
The theme of this little season here is what matters, and I want to just come right out of the gates with you, just start swinging for the fences. What matters the most in a clinical encounter to you or to your approach or in your opinion?
First of all, Doc, thanks again for having me. It's been a couple years, but I really, really appreciate it and appreciate everything you're doing for the chiropractic community in general. So I really appreciate that. Um, I in a talking with my colleague and mentor over the past like 6 months is real. And some people who may have heard me talk about this a little bit before, it's like when you're in school, you think I have to learn, particularly chiropractic school. It's like I need to learn the techniques. I need to learn how to adjust this. I need to learn how to adjust that. I need to learn the technique as best as I could. And then it's about accumulating techniques, and I need to learn all varieties of techniques. And then when you graduate, it's I'm going to take continuing education on this particular technique and that particular technique. And then you're 15 years out of school, and you realize the most important thing is not the technique at all. It's the assessment. It's your ability to do a quality assessment that ultimately is going to allow you to distinguish whether or not your technique worked. Um, so even having said that, though, it's tricky because then it becomes, okay, well, let's distinguish between what a quality technique or I'm sorry, a quality assessment is versus, maybe the not the best type of assessment. So I think what matters most in my clinical encounters now with patients is just really providing a global approach to an examination and an assessment that's going to let me know whether or not whatever type of therapy I provide is actually effective or how effective it actually is.
That's great. I am not looking for any specific answers, but if I was looking for an answer, that would be one of them I would look for,
Oh,
if that makes
good.
sense.
Well, that's nice. It's nice to hear that.
Let's laser focus that down to DNS.
Yeah.
What matters the most in DNS? What makes somebody a great DNS practitioner? If somebody was to walk in an 80-20 principle, their educational process in the DNS world, what's going to make them walk out the most successful?
Well, that's a good question. For me, and it's not only for me, but DNS is truly the foundation for all movement, posture, and stability. It provides us with an objective framework to distinguish quality movement, posture, and stability from maybe not so ideal or not so great or whatever, however you want to describe it, better and worse ways to move and posture and stabilize. So, first of all, coming out of a DNS seminar or understanding of the DNS approach gives you the objective framework to distinguish, yeah, that's maybe not the best way to posture yourself if you're attempting to do something. I use this phrase posture yourself. I mean, that's how I'm going to say it. Maybe this is a better way to feel stability and produce force. So it really ultimately comes down to understanding the basic developmental principles that DNS is based on that will just give you the it gives you the foundation to then be able to distinguish everything you're doing in particularly like a musculoskeletal orthopedic physical medicine type of a practice. you know Obviously I'm biased. I'm a DNS instructor, so I think that DNS is all I'm saying it is. But at this point, whether I'm looking at an assessment approach, whether I'm looking at a particular technique, a system, something, I am measuring it through the lens of the developmental principles of human motor development. And if it doesn't really correspond or correlate to that, or it kind of goes, it's antithetical to those principles, at this point, I just say, well, this is not a very useful or effective approach because it just doesn't have anything to do with reality about movement, posture, and stability anymore. So when I try to, when we take the DNS course, when I teach it or I'm a part of the teaching of the course, I'm always trying to stress that this isn't controversial. There are textbooks written on human motor development. It's not controversial to say that all humans develop their ability to stabilize their low back and pelvis in about the same way, using the same patterns, using the same principles in the same time frame, and on it goes. Now, what might be controversial, I guess, is when you start to apply those principles to older people, to
Sure.
adults, to more functional type of movements and exercises. But the fundamental principle and pattern by which a golf swing is based is still the fundamental developmental principle. Whether or not you want to swing a golf club, whether or not you want to pick your grandkids up, whether or not you want to roll over in bed, you're using the same fundamental movement patterns that neurodevelopment you gained over that first year or two of life. So you can push these out, but ultimately the patterns don't change.
I would
So I
I
think,
would envision it sort of on a bell curve, right? Like you can be a couple standard deviations from the standard pattern or movement. You could. You might
yeah,
suffer consequences further out you go from the mean,
yeah,
but
100%. And that's exactly the right perspective. And that's ultimately, if you are paying attention in a DNS course, nobody
a
in
big
a
ask
DNS
there, big
course.
ask.
Yeah, believe me. We just had the symposium or the World Congress 2 weeks ago or last week in St. Louis with all of the instructors and some of the prog therapists there. And, we're in the room. I'm in the room with the other instructors listening all day. And it was tough for us to sit for 8 hours and pay attention all day, let alone students who may not have heard some of these things before. So it is difficult. It's a difficult ask. But yeah, that is the right perspective. It's nobody is saying that a golf swing is fundamentally bad or wrong, or this particular way to deadlift is particularly bad or wrong. It's just what you just described. It's the further away you get from the objective standards from neurodevelopment, the harder and harder it's going to be for you to effectively and efficiently do what you're trying to do. You might be able to do it once or twice, but ultimately, if you continue to use that pattern and continue to use that way of stabilizing, you will ultimately break down in some type of dysfunction. Might not immediately be painful or injury producing, but it will be ultimately dysfunctional. So I think coming out of a DNS course, you should realize, okay, there are standards, objective standards for movement, posture, and stability, and I can apply these in my practice to start to distinguish better and worse ways of moving.
That's an important distinction because you can use the word objective, and many people can assume there is no objective to observational or observing movement patterns or
Mm-hmm.
observing positioning, that it's all sort of subjective on some level.
I
But
would agree.
you can objectivize subjectivity, could you not? I don't want to get too
That,
dark down in the weeds, but obviously,
oh, I like that. I
you
like.
can objectivize
I'm a
subject,
nerd. I want to get down in the
and
weeds.
it could be binary. It could be like that's good or that's bad, like, sort of an FMS approach, right? That's
Yeah,
normal,
yeah.
good or bad. But is there a deeper level to the objectivity of this subjective thing called observation?
Perfect question. Perfect observation. No pun intended. This is ultimately this is and again, this is why I was so impressed with the instructors in DNS. I had taken DNS. I took my first DNS course in 2007 and was made an instructor in 2019. And of course, I had a relationship with some of the instructors before then. But when I went to Prague to become certified as an instructor, I was in the instructor's course, and there was argument and debate going
Sure.
on about these principles. It was a party. It was fun. At the end of the night, it's a party and it's fun. And we're all having a good time. But I was very impressed with how none of these principles are like, this is what it is. And we're, this is what it was 12 years ago. And this is what it is today. And just, there was argument, and there's still argument to this day about definitions and principles within DNS. So what you're describing, I can just talk about it a little bit because I talk about it in our seminars. There's a concept in DNS, a fundamental principle called joint centration or functional joint centration. And, in one sense, the definition of this principle has kind of been described a little differently and altered or changed or updated over the years. Ultimately, I just described this at the World Congress, that DNS is a neurodevelopmental approach to movement and stability. The concept of joint centration is fundamentally a neurologic principle. It is not a biomechanical principle. Biomechanical principles, yes, can be subjectively observed and inspected. You will never get a 100% ability to, is this person's angle at this particular angle, rotate. You can get an idea. But when you understand the concept of joint centration as fundamentally a neurologic principle, well, how do you test neurologic principles? You could neurologically test people. So we will test whether or not someone is using a functionally centrated joint strategy based on inspection and observation. I'll look and see, does this seem to look like what I understand a centrated joint to be? Yes, and you can get a pretty good idea of it. You're not going to get 100%. I can tell you 100% whether or not you're using a centrated joint strategy by neurologically testing you before and after you use that strategy. That once I test you before and after using neurologic tests, then that is the basis for me of an objective standard. That is, your reflex was this. Now I have you do the strategy and I come back and your reflex changes. That's an objective change. Your muscle strength was this before and now it's this after. That's an objective change. That's not a subjective change. Your range of motion, passive range of motion in the joints was one thing before your strategy. Then we used the centrated position and now it's a different range of motion. That's an objective standard. So that's kind of where myself and my colleague, the other DNS instructor, Robert Lardner, that's how we approach the assessment, and that's how we approach joint centration. We are trying to get better and better objective standards and objective tests to tell us whether or not our treatments are effective. Because what you pointed out is exactly right. I can look at somebody and go, that looks pretty good, but ultimately I don't know. You can't, because then it's going to be me asking them, well, how did it feel? And then now you're off in the subjective realm.
Whoa, yeah,
Yeah.
for sure.
Yeah.
And that's all part of that clinical audit process, as well as, there are
Exactly.
the objective ways to go. I don't know if they're DNS standards, but there are certain clinical standards to use outcome assessment tools and choose or add that to your mix. And that can
Yeah.
objectivize what you're doing. On the subject of what matters with DNS, we're going to add a third layer, and
Mm-hmm.
that's the patient. What
Ooh.
effect do you see applying a DNS approach to a patient? Or maybe I should do it this way. If in your experiences you see somebody go through this process, and if it's a pediatric case, maybe they're not giving you a direct feedback. Obviously, the parents might in that case. But any patient in general, what experience do they have going through the process? What discoveries do they make? What kind of aha moments do they have once they understand what you're trying to do or what you're trying to teach and impart to them? as they leave the office and have to live the rest of their life?
Another good question. I think, in one sense, a lot of what I'm doing within my patient visit is a lot of patient education. I'm teaching them what my understanding of a core exercise is, or stability is, or how, an effective posture, and why I think this is an effective posture. So I'm like teaching them and talking them a lot throughout the visit, and of course we're doing things practically, so that way, at the end of the visit, I could just reference even this morning. I had a tennis player, a middle-aged woman tennis player, with some low back pain, lower rib pain, low back pain, and ultimately she did have a low back issue. It wasn't something out of the ordinary, but you know her approach to treating the low back was basically hamstring stretches and just stretch my back out by repetitively bending forward. And I ask her to breathe, and it's all chest breathing and chest elevation, literally almost paradoxical breathing of sucking into her belly when she would breathe in, and me just describing, hey, there's a particular way we actually control and stabilize our low back and pelvis. It's based on what babies do and what every single human does. And you're using a particular strategy, and when I show you use this strategy, muscles weaken, your range of motion in your hips decreases. This it's particularly tender in your low back, and now I'm going to have you use my strategy, breathing, using a posture that I think is a bit more effective, and a way to do this breathing and abdominal bracing that I think is a little bit more effective. And now when I rub that really tender spot before, you're not jumping off the table. And then I checked her hip that I hadn't really touched, and it's full range of motion in the hip. And she laughed out loud. She said, "You didn't touch my hip." I said, "I understand, but if your hip truly isn't an issue, when we do these things that are normal, that the brain recognizes, the central nervous system recognizes, it will standardize things. It will relieve things that aren't truly a fundamental problem. If she obviously had something significant going on in her hip wouldn't get any better unless I treated it." But she laughed out loud, and then she stood up and she's, "My God, I could actually, breathe into this now. I can feel how loose it is." And I just said, "Well, this is." I always use the phrase, "It's nice when it works." It's very nice when when the patient gets up and goes, "Oh my gosh, I could really actually feel the difference here, and I understand why what I was doing before might not have been the best thing, and why this seems to be effective." So I'm constantly educating the patient and trying to point out all the changes I'm making within the visit, because I laugh, like if I teach a seminar, and I'm lucky enough to teach seminars, and I demonstrate some of these things to other professionals, I'm not the greatest clinician in the world, but they're like, "Oh my gosh, that's amazing. You were able to do this, this, and this." And I tell them, I laugh and say, "I wish you were in the room with my patients, because most of them have no idea the miracle that I just performed for them." I
Right.
have to point out every single thing, that changes that I'm making, to get buy-in from the patient to say, "Oh yeah, I actually am seeing differences here." So I think that's part of the clinical encounter too, is at least me personally, have to constantly like show them before and after all these changes, these positive, good changes that I'm making.
You say it like it's a bad thing, but I want to make a point to the burgeoning young clinicians out there and aspiring master clinicians out there. What we just experienced here was somebody who, utilizes the clinical audit process effectively, uses, you know, test, test, reset, test again process appropriately, and doesn't just talk to the patient about what's happening and then wait for a result, but shows or has the patient experience what they're going through and then give the feedback. So we had a moment here where you talked about what the patient felt. And I think some younger or inexperienced clinicians were like, "Oh, now we're going to feeling and we're going to sensations and symptoms." Like, no, you had her feel the movement, or had her feel the pattern of breathing, and then had her feel going through whatever ranges of motion while using different strategies. And I think that's where a lot of young clinicians get lost along the way, is they want to explain these concepts, and good freaking luck trying to explain DNS, like explain it to a patient of like what you're in an encounter, and just like give your didactic lecture about what's going on, instead
Right.
of just getting them on a table, or the floor, or whatever process you use, and having them actually go through the scenarios and actually feel what's going on. And that's the big deal here that I think some younger clinicians miss, is they rush to explaining didactically or verbally what should be going on, and just losing the patient, just glossed over eyes, versus
Yeah,
getting
no,
them in there and getting them to actually feel what's going on themselves.
I guess I mean, I can see that. My own experience, I think early on, there's a lot of that didactic explanation to the patient because I'm kind of trying to explain it to myself
Right.
what's
Yeah.
happening. Like, why
Yeah.
am I doing this exactly? Oh,
Exactly.
yes, it's because I'm trying to connect this with this, and I'm going to have you. So I think probably that's a little bit of what's going on with them. Um, but yeah, I mean, for obvious reasons, I think we all understand, like, yeah, when I'm with the patient, I'm not talking about your abdominal wall muscle coordination. I'm asking you to do something with your belly, with your tummy. I'm asking you to press out, and I'm not asking you to brace and contract. You know, but you also are correct too. And this is a foundational DNS principle. It's very much about internalizing the feeling and sensation you are having while you're doing this. When I'm, again, with the patient this morning, I have them in a basic DNS position, and we're cueing breathing and bracing and the rest of it. And I'm basically telling them, okay, while you're there, I say, once it looks generally good to me, I say, okay, you don't have to think about it looking good anymore. While you're there, I want you to pay attention to what it feels like to breathe the way you're doing right now. Because when Dr. Bill's not there tomorrow, you're going to have some type of a way to remember what it actually felt like when you were in here with Dr. Bill. So I'm literally saying, remember what it feels like to breathe laterally or breathe out to the sides where my hands are now. Remember what it feels like to have your low back not hyper arched up and off the table when you're doing this. So, remember what it feels like to have your foot fully loaded on the ground here, because that's the thing you're going to have to remember tomorrow and the next day. It's not going to necessarily be the particular biomechanical posture I had you in. It's the sensation of loading into whether it's your foot or your back or your elbow, and the feeling of breathing and bracing when you're doing it.
Perfect. Now I'll give you a little leadway here so you can ramp up your thoughts about it. But I want to next ask you what matters to you. Why the heck do you do all this? Before you do that,
Mm.
just tell everybody about how they can reach out, how they can schedule, how they can look into taking some DNS courses, how they can ask you further questions, all that
Okay.
stuff. The pitch, man, give them the pitch.
Oh God. This is-
I only said that I only said that because I know there isn't a pitch.
Oh no, I'm laughing because I'm not a good pitch man.
When I have
You're asking the wrong DNS guy for the pitch.
when I have guests, I know they have a pitch. I never tell them to give the pitch. But when I know you don't have
They're
a
pitching
pitch, I'm
all the
like,
time.
pitch, yeah. You know what I mean, man. How can people
I
get a
guess
hold of
what
you,
I
and
would
how can
say,
they
so
expand
what
their
I would say is, if
curiosity?
you're interested in the approach to DNS and the DNS approach, obviously there are seminars put on throughout the United States and around the world. You can first go directly to the DNS website, and there are course listings for every single course, updated constantly. That's www.rehab, P as in Paul, S as in Sam.com. It's rehab, basically progschool.com. Separately from that, if you're interested in what I'm saying and the way I kind of present DNS, my particular courses that I host and teach for DNS, I put them under the company and heading of IMTR IMTR Seminars. That's Integrative Manual Therapy and Rehabilitation Seminars. You can find IMTR Seminars on Facebook and Instagram. You can follow us on social media, and there's always courses updated through the social media platform. If you have any particular questions for me about any kind of DNS principle, whatever you like, you can email me at drbill@imtrseminars.com, and I'd be happy to answer any of your questions.
And we put all your events on our website too. So our events page listing
Yeah,
has
thank you.
all the
Thank you.
IMTR courses as well. So now here's how we hit the finish line here. What
Mhm.
has DNS given to you? Why does it matter to you? What have you gotten out of it? Besides, you can feed your family and
Well,
and you feel pretty like a pretty hot shot clinician now and all that sort of stuff.
let me tell. I mean, speaking on that, I mean, you can cut this whatever you like, but I'm in Prague last summer for the final Prague D course for people who take the seminars to be certified. And I'm there with all of the other DNS international instructors. It's a nice thing. I'm in the back of the room in Model Hospital. Somebody's giving a lecture. I'm in the room with 100 students, and I'm feeling good about myself. I'm a big DNS instructor, and my phone connects to the hospital Wi-Fi, and a voicemail shows up on my phone. And I check it, and it's basically the voicemail just goes immediately into, yeah, Dr. Bill, I got a bill from you in the mail. Who do you think you are charging me $150? So I didn't get better from you at all. How dare you send me a bill? And I'm thinking, this is just absolutely now. I couldn't even recognize the patient. I had no idea. After I looked it up, it was from 7 months ago. I saw them one time. This was their deductible, basically, and they're bitching at me for having the audacity to spend an hour with them and charge them $120 and send them a bill in the mail. And I'm thinking, yeah, big time DNS instructor here, halfway around the world, and some patient couldn't care less. They're bitching at me.
Let me guess, you
Um,
sailed your yacht to Prague, huh?
yeah, no. Yeah, no. So I forgot. Oh, what has DNS given?
Yeah, what is it giving to you
So
besides a headache?
yeah, right. No. You know, get like I was always I'm interested in how things actually work. And the range of topics on, I mean, I'll read a physics book, nerdy from beginning to end. I liked school, all the rest of it, academics. So the idea of I can actually get foundational information on how the body, how the neuromusculoskeletal system actually works. And it's not, like I said, it's not really controversial. And I can apply that to my patients. I mean, that's really what it has given me. And I mean, yeah, it makes me a little cocky too, because now I see, I look at things, and I can quickly go, no, that's bullshit. That's bullshit over there. That's maybe not the best way to do things over here. Um, but I don't think that it's wrong. I think that it is right. So it gives me the perfect lens to analyze my patients, to problem solve. They're all puzzles, basically. Every single one, I'm collecting a bunch of information with my assessment. Those are the puzzle pieces. I'm trying to put the puzzle pieces together through the lens of DNS. DNS gave me the lens. Before that, I've heard the transverse abdominis is really important. I heard breathing is somewhat important, and there's a plumb line, and I didn't have really an objective framework. So DNS really gave me this objective framework that is universal. And it doesn't, like I've said in seminars, it doesn't make a difference if you're from Chicago or the Czech Republic. These patterns are universal and fundamental. And it isn't easy though. I mean, that's the other thing DNS gave me is it is. I mean, I'm literally with the instructors 2 weeks ago, and we're arguing about rolling patterns, turning patterns of babies that I thought I knew as a DNS instructor. And I'm having a conversation about, well, wait, is it this? Is it this? How do we apply it to the golf swing? How do we apply it to just rolling over? So it is constantly being updated. And even though there's a framework, it does take a lot of understanding. I have things drawn out, notes drawn out that I found in my office from like 2008 of diagrams that I drew out of how the muscle chains function using these patterns that I'm still not exactly 100% certain that this is how they're. Now, I use them on patients and I check them and test them, and it seems to be working like that. But it's constant. Being the academic kind of nerdy person I am, I like the fact that it's not just totally settled and I can just go sip bourbon and not have to think about it too much.
Will you or ever could you view human locomotion, pain, human physical existence through any other lens or without the lens of DNS going forward?
Yeah, that's. I mean, I guess if the truly scientist answer is, of course, if I get better facts, I'm gonna apply those to the way I move forward. But I don't think there's ever going to be anything that is going to overturn the approach or the principles of DNS,
Just
because
checking, just
yeah,
checking.
it might subsume DNS.
Sure, absolutely.
There might be something maybe a little deeper, that more foundational, but it's never. I don't envision a time where I'm going to say, well, I can throw the DNS principles out because they're bullshit now. It's something else. Not just to give you an example, and not that I'm speaking negatively at all, but originally, coming out of chiropractic school, I was doing a lot of McGill type rehab things, curl up, for example. Now, at this point, I've totally thrown out a McGill curl up. For me, there's no reason to do that. Not that it's 100% bad. It's just I have better ways of getting at the abdominal wall musculature for stability. So I use that, and I throw the McGill curl up out. I don't see a future where I would throw out the ways that I'm, facilitating core stability based on DNS. I couldn't see a way.
Yeah, you don't throw out
The
the
DNS
core.
baby with the bathwater.
Yeah, the core thought process just because of a bad approach to it or suboptimal approach. There's always better, more optimal approaches to reach the same concept.
Yeah, yeah.
All right. It's hard to do podcasts where you completely agree with somebody. Next time you come on, let's find something we disagree with, and we'll go. We'll
I
go back and
appreciate
forth.
it.
But I appreciate you and all that you've done, and all the folks that you've educated obviously have gone on to spread a tremendous amount of
Oh, that's
results.
very nice. It's very nice.
So that's an
Very
impact
lucky.
you should be proud of. Crack open a cold one for that.
I'm very lucky.
And cheers to you for future success. And thank you so
Same to
much
you.
for contributing to the FTCA and always being willing to educate.
I'll continue. Like I said, I can't. It's amazing what you've done with this community. So I really appreciate everything you're doing as well.
I just want folks to, whether it is ethically aggressive or whether they do it with taste, which I'm not always the best at doing it tastefully.
Yeah.
Sometimes you've got to crack a couple bowls in the china shop to get people to pay attention. I just want people to think and to act in a way that prepares not just this profession, but just their communities and maybe even humanity in general for a better future, a better way to live, and a better way to operate this profession. And you are an exemplar of that. So I love having you on the podcast.
Oh, thank you again.
And if we hung out a little bit more, I'd even consider you a friend. So let's make that happen.
Well, I was teaching in Portland area last year, and I might be back. So maybe
All
we'll
right.
have to check in.
I'll check out the class. I'll check out the class. I am one of those that likes to what is an autodidact. I learn everything at my own pace, on my own terms, and I very rarely ever got into the alphabet soup of needing designations or certifications.
Yeah.
But sometimes you got to sit down in that damn classroom and you just got to sit through the weekend or the months or whatever it takes and go, oh, those are the final pieces that I did not round out that now put the cherry on top of this thing. And so next time you're in town, I'll be there.
Sure. Awesome.
All right.
All right, Doc.
Thank you very much.
Thank you.